Hi, everybody, and welcome. Welcome to our monthly show, the Lafora Talk Show. This is season 3, episode 8. I cannot believe Lafora Talk Show has been going for 3 years. I am your host, Tanya Friedman, CEO of Kinetics USA. We help healthcare organizations all over the United States with the nursing shortage by bringing in internationally educated nurses by direct hire. Our topic today is clinical differences in the ED. How is working as an ER nurse overseas different to working in the United States? We are excited today to be joined by our panel, who are going to be sharing their experiences, their insights, their feedback to all of you. So I'd like to welcome Sarah. Hi, Sarah. Welcome.
Hi, thanks for having me.
Welcome. Also, Holly. Welcome, Holly. No stranger to the Lafora Talk Show.
Hi, everybody. Nice to see you again.
Also, Ivan. Please welcome Ivan, everybody.
Hi, hello, good morning.
And last but not least, Ben.
Hey, good morning.
Okay, great. Well, thank you, everybody, for joining us. If you are an ER nurse anywhere in the world looking to come to the United States, this show is for you. And if you are not an ER nurse, this show is also for you because you're going to learn a lot about how orientation works in the United States, what the day-to-day responsibilities are of nurses in the United States, how technology might differ overseas, how work culture might differ overseas. So we're going to be digging into a lot of topics today. Before we get started, I wanted to just give a shout out and thanks to the Lafora admin team, to Miss Jean, Paul, Louise, Anna, Kay, James, Nurse One, all of the Lafora admin who did such an amazing job of nurses helping nurses. If you have any questions, please feel free to put those into the chat. I see we've got a lot of people joining us already. Eunice is saying hi. Arlene is saying hi, everybody. Morning from Jamaica. ER emergency room nurse in the house. Welcome, Arlene. Chebet is saying hi. Ahia is online. Gigi is tagging a friend. Thank you, Gigi, for tagging a friend. This is what Lafora Talk Show is all about. Nurses helping nurses. Jansi's saying hi. Shirsat is also online. So please put into the chat where you are watching from. We like to see where everybody is. It's so fun to watch all our viewers from all over the world. So we're going to get started. A few months ago, we did a poll. And in the poll, we asked nurses in Lafora what clinical areas you wanted to hear about. And we did so we have a graphic of that poll. And the last month we did ICU, and this month we are doing the ED. So today we're going to dig into the ED. Okay, so let's get started. I'd like to start off with introductions. So Sarah, do you want to start off and tell us a little bit about yourself?
Yes, so I'm an ER nurse, obviously, that's why I'm here. And I've been ER nursing for over 14 years, qualified in the UK, and then transferred my license to the USA around about 8 years ago. So started in the UK, then transferred to the US, and worked as an ER nurse and then clinical nurse educator after I got my master's degree.
Yeah. Okay, thank you, Sarah. So Sarah's an ER nurse and will be able to share her experience as an international nurse as well as an educator. So we really are excited to hear from Sarah. Holly, do you want to introduce yourself?
So my name is Holly Musselwhite. I am a registered nurse of 22 years. I have worked with acute care settings and post-acute care settings. Never been an ER nurse, but worked with a lot of them who come from overseas and help them through that transition. So I work with Kinetics now, have for almost a year, believe it or not, Tanya. And I enjoy kind of understanding where the nurses are coming from overseas and how their previous practice and what they've been exposed to can help them transition and learn and grow here in the United States.
Thank you, Holly. So Holly worked with a nurse herself and worked with international nurses for many, many, many years, helping both nurses and facilities make that transition. Ivan, do you want to go ahead?
Hi, good morning, everyone. Yep. My name is Ivan Abarido. I'm graduate of Western Mindanao State University from Zamboanga City, Philippines. I'm a travel ER nurse. I'm sorry, I still have my scrubs. I just came back. I just came home from work, and I'm
You look
currently
good,
working in a yeah. I'm currently working in the BCS emergency department in the United States. So according to patient volume, yeah. And
Wow.
anyway, yeah, it's been a privilege to talk to you guys.
Thank you, Ivan, and thank you for sharing your insights and your experience. I know there are many people who are going to be interested in hearing about your journey and what it's like to work as an ED nurse now. And I know you're tired, so thank you very much for coming on this morning. And last but not least, Ben, you want to go ahead and introduce yourself, Ben?
Hey, good morning. I'm Ben Bryant Lanehart. I am a clinical nurse manager currently for one of the large travel companies here. I have been in healthcare in the emergency departments working as a nurse and a nurse manager for a little over 12 years.
Okay, thank you, Ben. So Ben is going to bring another perspective because he is an American ER nurse and has worked in many EDs. So we'll be bringing a very interesting perspective as well. Okay, so let's start with the basics, everybody. I think we'll maybe start with Ivan. What was it like working in the ER in your home country, and how is that different or similar to what you're experiencing now in the United States?
Yeah, honestly, I won't be able to talk for the ER nurses who work in the Philippines because I just worked for like a few months as an ER nurse in the Philippines. So there are like lots of differences um, in our job in the ED in the Philippines and the job in the ED here. I work in a government hospital, so I'm not really sure what's the how they do in the private hospital or what's their setting in the private hospital. But basically, where I work at before, the it's divided to specialty. Like there's an area for patients who are like under the internal medicine. Then there's an area for patients who are under surgery, and there's an area for patients who are OB patients, and there's also an area for pediatric patients. So the EDs in the ER doesn't have their own private room. So basically, it's just like an open space with like cubicles and curtains that separates the patients. And Here in the United States, as we know, the ED are divided into depending on which ED you work at. Like I work in the one of the biggest ED in the United States now. So our ED is like basically 125 beds, and it's divided into pod. One pod is equivalent to 12 rooms, and per pod there's like it's staffed with three registered nurses, one charge nurse, and techs. Um, yeah, so it work wise, we 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 function here like a function nursing. So there's like triage nurses that are assigned in triage. There's like pod nurses that are assigned in the pod, and there are charge nurses, and there are like service managers and directors. Then so
Okay. So Ivan, that gives us a very good overview of how things might be different, for example, in the Philippines as opposed to in the United States. Sarah, how is your experience different or the same as Ivan's? Because you were also an international nurse coming from the UK to the United States.
Yeah, one thing Ivan touched on was the ratios that you might have. So he mentioned you have so many nurses to patients. In the UK, there's no ratios. In California, there are ratios, and that varies also from state to state. I've trained and worked with a lot of travelers from AMN actually, and they also would tell me about different states that wouldn't have ratios, and California was great because they did have ratios. So it would be 4 patients to 1 nurse.
Okay.
Or if it was a high acuity, it would be
Sarah,
and the charge nurse would make that designation.
Okay. Sarah, you seem to have a little bit of Wi-Fi delay there. Okay, so let's move to Ben. Thank you, Sarah, for sharing. So Ben, obviously, there are different size hospitals, different kinds of levels of EDs. Can you maybe share with everybody who's joining right now how different hospitals might be different in terms of the ED?
Yeah, so you'll have your traditional role settings, which are a little bit more remote, and some of your access may be quite different than if you're working in a metropolis area, which typically are larger volumes. You'll also have your hospitals that are divided out into trauma centers. So you'll either have non-trauma hospitals that see a lot of walk-in patients. You'll also have level 1, 2, 3, and 4 trauma centers, level 1 being the highest, and level 4 being the lowest of those. Patient volume, you'll get your walk-in patients, but you'll also get EMS transported patients, sicker patients going to those level 1 trauma centers, as well as those rural community setting hospitals as well.
Okay, so not all the facilities are the same. Holly, in your experience, where do you see, and I know we're going to dig into the details, so maybe just at a high level, where do you see international ED nurses struggling the most, just generally, when they come from overseas to working in the United States?
The biggest struggles probably have to do with new technology and a lot of electronic medical record keeping versus handwriting things on paper or not using computers much before. And I would say also learning what some of the protocols are, both for the facilities as well as some of those more best practice care pathways and things like that that may not be standardized where they're working now, and yet they provide a process flow for the nurse. So getting familiar with those things, and then sometimes the pace is very different. And so they may struggle with how quickly do I need to get up to speed and be working at the same pace as somebody else.
Okay, so a lot of good insights there, and we're going to digging into some of those things as we move through the next hour. If you are joining us now, today's topic on the Lafora Talk Show is clinical differences in the ED, how working as an ED nurse overseas is different to working in the United States. We actually did a poll a little while ago in Lafora, and it came out that the ED was, I think the first one was the ICU, and the second was the ED. So a lot of people interested in how the ED is different overseas as well as in the United States. And I see we have Eagle joining us, Cecil joining us, Mohammed is saying hi, Ahia saying hi, to Hami, hope I've got that right, she's saying hi. If you have any questions for the expert panel on the ED, please put them into the chat, and I'd be very happy to talk about those. And Anna is saying, hi, Kinetics and Miss Tanya. Hi, Anna. We met in New York. Great to see you here. Megan is saying, Megs is saying hi. So a lot of people joining us. And if you have any questions, please make sure to put them in the chat. Mike from UAE. So welcome, everybody. Okay, so let's talk. Holly mentioned how orientation or adapting to the US might be different. So let's talk about orientation. So Ivan, in terms of your orientation, I know that you didn't work in the Philippines for very long, but how was your orientation in the Philippines different to the orientation you received in the United States?
I did work in the Philippines for like 6 years, but not mostly in the ED. So they do, yeah. But they yeah,
I thought you were only in the Philippines for a short time. My apologies.
No, it's okay. I mean, anyhow, so it depends which hospital you're going through. So mostly in the Philippines, like before you would be able to work in a specialty area, you need to work like as a volunteer nurse that you like volunteer for like 3 months to 6 months. So it means when you say volunteer, you're not paid. So they'll train you on how to become an ED nurse, and for like 3 to 6 months, you work like as a staff nurse, but you are not paid. So anyhow, so in the United States, like when I first worked in the ED, so I was given like I think 3 months of orientation, um, and then to be able to learn things, all the procedures, learn about the technology. But as a traveler, or when I moved first to become a staff nurse in another hospital, so if you're already a seasoned ED nurse, then the orientation would be like 6 shifts. So that would be for 2 weeks. Then as a travel ED nurse, the orientation would just be basically depending on where you're gonna be assigned. So one day orientation, and sometimes like just like half shift orientation. So because you're already more familiar with the EMR and with everything. So but yeah, the training here is definitely better than in the Philippines, and as we talk about the technology as well. I mean, as what I think Holly uh, told us earlier, yeah, it's true. I mean, I think yeah, told us earlier about the challenges here. Like when we first came here, there's like lots of things that we definitely have not encountered in the Philippines. Then.
Yeah, and it's not just the clinical aspect, but all of the cultural differences
Mm-hmm.
that are so difficult as well. And we've done many shows on culture shock. So if anybody's interested in those shows on culture shock, please watch on the Kinetics USA website or our social media. And we have many shows on culture shock. It's not just the clinical differences. And Sarah, Ivan said that he had 3 months of orientation when he came to the United States. What was your experience like coming from the UK? And how did the orientation that you get in the US differ from the orientation in the UK?
Can you hear me now? Let
Yes.
me know if it's lagging.
Yes, we can.
My experience was amazing. It was actually tailored to my needs. So we gave 3 months, and every week we would meet with the manager, and yeah, it was a really great experience. And one thing I would tell all of the nurses coming over to work in the US is that don't be afraid to voice how you're feeling, how you feel like you're learning, because your manager's door is always open. They're there to help you. So if you feel like you're needing more shifts on your orientation, that's always an option.
Okay, so I'm glad to hear that your experience was a positive one, and hopefully for everybody watching, it will be a positive experience. But it doesn't always work like that. Holly, what can a nurse do if the experience maybe wasn't as positive as Ivan or Sarah, and they didn't feel that they got what they needed from an orientation perspective? What can a nurse do?
And it kind of piggybacks on what Sarah was saying, which is speak up, but don't wait to speak up. So some people, day after day, someone may be coming to you saying, how's it going? And you say, I'm fine, or I'm okay. And inside you're like, I'm not really okay. So you have to actually voice the truth. And certainly there are things you're going to be celebrating day to day. I did this, I learned this, I accomplished this. But those things that you're struggling with, you need to speak up as soon as possible to say, can I have more practice? Do you have some reading that I could do, or a training module, or some time with the educator? And so if you wait until, time has passed and then you start asking for more help or more time on orientation, that becomes a little bit more difficult. The other thing is sometimes we don't have personality matches between a preceptor and the new nurse, or the new hire nurse, I'll say. So at that point, sometimes asking, can I shadow someone else? Can I, have a broader experience can also help. Speaking up is the biggest thing.
Yeah. And it's often hard for international nurses because in many cultures, taught to be timid, to be shy, not to speak up, not to be assertive. So I think that's one of the biggest transitions that are really, really difficult for many international nurses. And Ben, in your experience working in the ED and managing in the ED, being educated in the ED, can you give us an overview of what an international nurse might expect, just generally speaking, from the ED orientation?
Yeah, I think they should be able to expect competency-based orientation. So orientation is really kind of centered and tailored around you, your learning aspects, what areas you feel that you need more education and experience in versus areas you feel as though you're comfortable and maybe have already mastered. And really just centered around and tailored around you as an individual. So it's really important that you're engaging and speaking up and saying, hey, these are areas that I feel like I could use more exposure and more education in, as well as those areas that are saying, I feel like I'm comfortable in this area, and being receptive to that feedback that's provided to you in those areas.
Okay, thank you for that. So Ivan, and I think Sarah also spoke about doing travel nurse. So as part of AMN, Ben, the largest healthcare staffing company in the country, talk to us a little bit more about the orientation for travelers. I mean, Ivan was saying he got 1 day of orientation. There are many international nurses that are very interested in travel nursing, and we've heard some, stories about people who go straight into travel nursing, and it's very, very stressful. Talk to us a little bit about that, because it's obviously something that can be a great goal for many nurses, but how easy or difficult is it for an international nurse to go straight into that kind of role?
So when the international nurses are typically brought in for a long-term contract, and orientation is very much very similar to as if they brought in a new grad nurse from America to start on the floor. So typically what they would do is a 3 to 4 month orientation that would be competency based. It would kind of start at the basics, which is very different than somebody who's traveling, who's used to American healthcare and is traveling from American hospital to American hospital. So it's a little bit different, more tailored and centered around new grad nursing type orientation as well.
Okay, thank you, Ben. So I think important just to clarify, when Ivan and Sarah are talking about travel nursing, they're talking about traveling around as an experienced nurse in the US. And the orientation that you're going to get for that is different, as opposed to international staffing, where there are some excellent staffing companies that give very strong orientation, and those are more long-term assignments. So I think just important to differentiate between those two different areas. Okay, let's talk about the day-to-day, the on-the-job of what it's like working as an ER nurse in the United States. Ivan, what was the day-to-day like in the Philippines? And how is that different to the US?
Oh, the day-to-day ER nurse life in the Philippines, like if you're in a government hospital, so it's like a flavor of the day, because like there are days wherein there's like lots of patients coming in with acute gastroenteritis. Like, so basically, like just most of your patients are AGA patients, then PTB patients coming like with hemoptysis every day. I mean, in 1 day time, so that's the flavor of the day, and like or gunshot wounds coming. So that's like how it is, or how's the flow in the Philippines then. So as I've said, so you're like just focused on one specialty. Like if you're assigned in the internal medicine, so for that day, then basically your patients would be all internal medicine patients. So I'm not speaking for the private hospitals. That I was just able to work in a government hospital in the Philippines, and for surgery as well. If you're in a surgery, then basically you're just like focusing more on surgical patients.
Okay, so some similarities and some differences. ED, as everybody knows, one of the most high-paced, stressful nursing roles that you can experience. Sarah, what was it like in the UK as opposed to the US, just in that day-to-dayness? What was the same and what was different?
It was pretty much the same, actually, apart from the ratios. So you would go in at the start of your shift and you would see a charge nurse and you'd be given your assignment. But as opposed to what Ivan said, you stick to one specialty. So it would be the ER. So you would be given your assignment in terms of, are you in fast track? Are you in resuscitation area? Are you in triage? Or are you break relief? And you would stick with that assignment until you were told otherwise by a charge nurse.
Okay. So the day-to-day, though, pretty much the same, it sounds like?
Yeah.
Okay.
Yeah, day-to-day the same. It's hard to actually give a routine of the ER because it's so fluid and you have to go with the flow. But that's what you would do. You would start off your shift, see your charge nurse, give it as, giving you delegations. Mm-hmm.
Okay. Thank you, Sarah. So, Ben, can you talk a little bit about the day-to-day of an ED nurse and how that has been during the pandemic? Obviously, we're now at the tail end of the pandemic and moving hopefully to a new phase. But what has that been like? And also, do you see anything in the ED changing now, kind of as we move to a more post-pandemic phase?
I think we've adapted fairly quickly in the emergency departments. One of the the largest changes for us was masking in the emergency department and making sure that all of our patients are masked as well. That was a little bit different than pre-pandemic. Also, we changed a little bit of our flows through some of our emergency departments, kind of depending on how they were set up, and changing your walk-in areas, the way we brought patients in. So that changed up a little bit. And a lot of the autonomy. So the ER is a very autonomous area. You're responsible for a lot. And having that ability to recognize some of those decompensations with patients and what protocols you had to act on those, that changed for the better for the future for emergency departments as well.
Okay, so that's interesting to hear about those changes. Ivan, I know you're working in one of the biggest EDs in the country. Did you notice, were there things that Ben's just mentioned, like the flows or the walk-ins, did that change in your ED?
Oh, yeah, I mean, definitely would speak like when the pandemic first started, but I was in a different ED during that time. So it was like everybody was afraid to go to the ED. So basically, like, it was a very quiet ED at first.
Yeah.
Like, no, there were no patients coming, like only the possible COVID patients were coming. So, and all the other nurses coming from other units are also in the ED because, like, during the time, like all the other units, not all, I'm saying that the surgical unit were shut down and many other units were shut down. So basically, they were there to help us out. Eventually, when they came to learn about COVID and the people got their vaccine, so there were also like lots of changes. Patients started to come back to the ED, but visitors were not allowed. So I mean, mask was mandated for everybody, and we need to thoroughly clean all of our rooms every time we see a COVID patients. And there was a time even that we need to like use ultraviolet rays. It's not like for all hospitals. It was in the hospital where I was like before. So, and eventually when everybody learned to know about COVID and a lot of people were more vaccinated, so the rules and policies change again. And I think nowadays it's like probably gonna return back to normal.
Okay, so a lot of changes and hopefully we're back to normal. Sarah, in your experience, did you experience a lot of changes as Ben and Ivan were speaking about?
Yeah, definitely. Having to quickly adapt to what we thought was going to be a huge influx of patients. But like the same as what Ivan said, we didn't see that many patients in the beginning. So again, having to adapt. I also helped a lot of orientation from nurses from other units. But now I haven't been there for a while, but I hear that things are getting back to normal in terms of acuity levels. So people actually going back to their own doctors and finding out that they've neglected their health. So the ERs are now actually very busy.
Yeah.
But yeah, lots of changes, lots
Yeah.
of adaptation.
Lots of changes, adaptations, getting back to normal, but very busy normal, because lots of people who maybe missed out on getting treatments and things that they probably would have normally got if it wasn't in a pandemic world. Holly, the nursing shortage is across the United States, and obviously the ED is no different in that there are shortages and that the pandemic has created even more shortages. What can an ED nurse do to prepare for coming to working in that day-to-day environment?
I think that, like Ivan was mentioning, that there are differences where you may get comfortable in one zone of the ER or one specialty, whereas here you may see a mixed bag of issues and concerns throughout your day. So if you brush up on some of the common conditions and you review what are some of the best practices from the standpoint of U.S. healthcare practice, which are available online. Companies like Kinetics, we offer some pre-arrival transition training modules to try and help sort of introduce some of those concepts. And also, if you're just out there looking online for what ER nurses are sharing, what experts are sharing, getting familiar with the triage process, and attending shows like this would be important. I think if you don't have basic computer skills, please work on that. So if you can get access to a laptop to practice, navigating with a trackpad or even a handheld mouse, it seems simple and silly, but if it's complicating your ability to transition, you want to try and reduce that challenge as much as you can before you get here. So most people are using phones for a lot of what they do day to day in certain locations throughout the world. But if you can get access to computers and things like that and start becoming familiar, that's important. Practice standard things like inserting Foley catheters and really focusing on being careful with sterile field. Seems like such a basic skill, but the focus in the US is on doing things in a way that prevents potential complications. So even though you're in a hurry, the step-by-step processes that exist are there because research shows that's the best way to reduce risk of complications or injury to a patient who's already ill.
Okay, so it's a lot of very good tips there, Holly. And I want to give a shout out to Sarah, who has a channel where on YouTube where she gives a lot of pointers and advice to international nurses. So please check out Sarah Jeffrey's channel on YouTube. She has some amazing tips and pointers. As Holly said, there's a lot of information to share, and obviously LaFora is one of those areas, and that's why we love the LaFora admin team who give this opportunity to share information, nurses helping nurses. And just a shout out to Turs, to Arn, to G-Marge from Qatar, Gina saying hi, Farhad saying hello to you, Ivan. Said you were his clinical instructor during his university days in the Philippines, one of the best. So shout out to Ivan. Somebody's asking about OR nurses. So OR was the third one on the poll. So we're going to be doing a show in Little for a talk show on the OR. So there we have the poll up. We've done the ICU one. And today is the ED, and Med-Surg and OR are coming up next. Okay, so we have a question for the panel. Thank you for sharing some questions in. So Jairus is asking, is there any advantage if you work in a level 1 or 2 trauma facility? Ben, do you want to maybe take that question?
Sure. There definitely is a little bit of an advantage. There's going to be more education that's offered to you. There's going to be, you're going to see a wider range of patients as well. So you're going to get to see a little bit more of trauma process and how it affects your normal everyday health health conditions that the patient may present with. So you are going to see a little bit of a broader spectrum of the patient care, and get to see quite a bit of the injuries that are associated with that trauma care, which can present to any emergency department, regardless of whether or not you're a level 1 or not. Just the level 1 trauma centers typically seem to get that on a regular basis as part of EMS brings those in from the community.
Okay, so there you go, Jairus. Zell is asking, can you tell us about the workflow in the ED? Ivan, you're working in one of the biggest EDs in the country. Let's hear about a little bit more about the workflow.
Yeah, I mean, can I add with the advantages from level 1 traumas or level 3 traumas?
Okay.
Just in my opinion. So but there's also a downfall working in a level 1 trauma or level 2 trauma, because they tend to they have like these hospitals are usually they have like lots of policies, so you won't be able to be able to master your skills. Like, unlike if you work in a level 3 trauma, then you could like master your skills. Like, you can insert EJs, which is not for level 1 traumas, it's not like allowed, and sono IVs you can definitely use it in level 3 trauma hospital. So I'm just saying, basically, skills wise, it's also nice to be able to work in a level 3 trauma hospital, or hospitals that are not that doesn't have or not trauma hospitals, because you'll be able to like you'll be able to experience lots of things, or be able to I'm sorry, my brain's not working.
You did miss the whole night, Ivan, so that's okay.
Anyway, I was just telling, and I'm telling the nurses where I'm working at that definitely you're learning more skills when you work in level 3 or level 4 hospital trauma hospitals. Yeah. So anyhow, so for the questions, like what was the question again? I'm sorry. What was the
talk to us about the workflow in the ED?
Oh,
Zell is
oh,
asking. Yeah.
the workflow in the ED, may it be a walk-in patient or an ambulance patient, of course, starts with triage. So as what Holly was talking about earlier, definitely you need to learn more about triage. So here in United States, so they use the emergency severity index to be able to triage patients. So triage patient from acuity levels 1, 2, 3, 4, 5. When you learn how to triage, and you will be able to like prioritize where to put the patient, if the patient can go directly to a room, or the patient would be able to stay in the waiting room, like in our hospital right now. So it's the busiest according to patient volume. So we usually have like 80 to 100 patients in the waiting room. So it's actually a tough scenario for triage nurses, because you need to decide whether the patient needs to be a walk back or not. So where am I right now? If as soon as you triage a patient, if the patient is like a sick patients, then we're gonna mark the patient for PUD. As soon as the patient's marked for PUD, another nurse is responsible for assigning the room for the patient, which is the EMS nurse. So the EMS nurse is responsible for assigning rooms for patients. So she will assign the room for patient, then we'll put the patient in the room. Patient will be assigned to a nurse. Afterwards, the primary nurse will be taking care of the patient, and the primary nurse will do his or her primary and secondary assessment. So in different hospitals, you can throw in your set of orders. Like, if the doctors are busy, then you'll be able to throw in a chest pain set of orders or abdominal pain set of orders, and you'll be able to start your IV, draw blood, sent to the laboratory. But in level 1 trauma hospitals, you usually need to wait for, since it's a teaching hospital, you need to wait for the doctors to assess the patient, and of course you need to give time for the doctors to be able to like study or do their assessments and put in their orders. So it usually takes time. So the pacing is usually slow in level 1 trauma hospitals then. So anyhow, after that, you'll start your line, do your EKG, draw blood, send it, and then you wait for results. And after everything's sent, then the next step would be for the doctor to evaluate results. Then after that, then the last step would be for them to decide on their disposition, whether they're going to keep the patient or admit the patient, whether they're going to discharge the patient, or whether they're gonna transfer the patient to another hospital.
Okay, so that gives a great explanation of the workflow. And as you're speaking, I'm just thinking how I love the Lafora Talk Show, because for many international nurses, if you're sitting outside the US now and you hear what Ivan has just explained, it just gives you such a great idea of what to expect. And that's where knowledge is power. The more you can learn about what's coming and how to empower yourself, the better equipped you're going to be when you arrive in the United States. So we have some questions coming in now. And Zell is saying, thank you, well explained. So there we go. G Marge is asking, sir, in regards with the triage, are you using the CTAS? CTAS. Ivan?
As I mentioned, it's a ESI, Emergency Severity Index. I'm not sure if CTAS is Canadian triage system, but they're similar, because I think the Canadian triage system is also like, I think it's 4 levels or 5 levels. But yeah, you're gonna basically triage like level 1 is the urgent emergent patients, like the patient needs to be like attended right away, like patients who are who are like on cardiac arrest, or the patient is on respiratory arrest, and definitely you'll tag the patient as one. The patient needs to be brought to a critical room right away. So I'm not sure exactly if CTAS is Canadian triage system, but
Yeah.
we're not using Canadian.
Yeah, Sarah, Holly, Ben nodding their heads, and JR saying, yes, that's Canadian. JR is saying, yes, I think the majority in the US are using the ESI. And in Arlene is saying in Jamaica, they use that as well. Ben, is that correct? Most hospitals here use the ESI.
Yes, most hospitals here are using the ESI triage system.
Okay, thank you. So that's kind of a good segue to moving to our next topic, which Holly actually touched on, which is the technology piece. So we want to dig a little bit deeper into this. Sarah, what were the technology differences in the UK as opposed to the US that you experienced as an ED nurse, if anything?
Oh, when I first started nursing, there was no technology. It was all paper charting. Such was when I started.
In the olden days, Sarah.
But now, yeah, then I was part of the training and the enrollment to the ER, the training process when we moved to computer charting, which was great.
Okay.
Yeah.
So not a huge amount of difference for you in terms of.
No, it's clinical charting. It is what it is. You write what you see, and if you don't write it down, it didn't happen.
Okay.
Those were the rules.
So if you're coming from a country like the UK, like Sarah did, really not a huge transition. I mean, you might have to learn a new system, but you've still also had that experience of working with electronic medical records. Ivan, what was that like for you coming from the Philippines in terms of technology?
Well, yeah, it's what Sarah's mentioned. So definitely the charting, we're still using the paper system here. We're using the EMR. So for a paper system, usually they base it from nursing care plan. So we'll do the SOAP charting, and the EMR, definitely it's more specific, and you'll be able to chart everything from head to toe assessment. So aside from that, technology wise, of course, I mean, the Philippines, when you start your IV, it's just basic IV insertion. So here we have like lots of options, like if the patient is hard stick, so you'll be able to get the vein finder, or if you can't find still with the vein finder, and you'll be able to use an ultrasound guided IV insertion. And all of the rooms here are the cardiac monitors. In the Philippines, we don't have them. So, and we insert our Foleys here in the Philippines. The doctors insert their Foleys since they're residents. So there are basically lots of differences. Then you'll as what Sir Bena said earlier. So you definitely have an autonomy here. As an ER nurse in the Philippines, the order for everything here. As I've said, we can throw in a set of orders and we'll be able to start the care of the patient then.
Thank you, Ivan. So obviously technology is one of the biggest transitions if you're coming from a country that does come from a paper, that are still using paper methods right now. And not only that, in the US, we're also seeing a lot of new technologies that are becoming available. And Ben, in the ED, what are some of the newer technologies or things that nurses might encounter?
I definitely think one of the big advances that we've had in the last several years as it comes to electronic charting systems is our scales and screens. So now most of your scales and screens are built in. They help you identify things that are happening in the background. So a lot of systems have sepsis identifiers that are identifying some of your lab work versus some of your findings that you're documenting and charting with your vital signs. And they're helping you to identify some of those more critical situations which may be happening with your patient that you're not readily, maybe not on the thought process of. For instance, sepsis, stroke, patient, the possibility of patient violence and agitation. So we've come a long way with scales and screens based off what we're charting in our electronic systems and all that information kind of pulling together to give you an alert. And that's something that's been progressively happening for the last several years, which has been a huge benefit to the bedside nurse.
Yeah, so lots of changes and evolutions coming, which is great for nursing in general in the US, but makes it sometimes even a little bit more challenging for those nurses who are coming from countries where they still with paper charting. Holly, you spoke a little bit about how nurses can prepare from a technology perspective, especially if they're coming from a country that still has paper charting. And can you speak a little bit more about what you're seeing are the biggest challenges that nurses experience in terms of the technology and any other additional tips that you might have?
So I don't see as much narrative charting, but when it is done, it needs to be very succinct. But as Ben was pointing out, there's a lot of scales and things that are built in. And if you are using the EMR correctly and you're kind of making that something that is part of your thought process to let me make sure I get this charted timely, then you're more likely to capture things that may help you intervene sooner because the system is there helping you kind of put it all together. It's programmed that way. Using a mouse, which I don't even have one at my desk right now. I'm on a laptop, but using a handheld mouse in some ERs, they still have desktop computers, but a lot of times they have laptops with trackpads and things like that. So again, practicing just kind of clicking boxes and getting familiar with operating from that standpoint is helpful. On the internet, you'll also find exposure to some of the most common systems that are out there. There's little videos and things like that. It won't look identical because every system can usually customize their EMR specifically for what they're looking for. But you can see kind of how it might appear, some of the fields and the coloration. So the most common systems are Epic and Cerner. I think they kind of corner the EMR market. And there are things out there that you can look for related to that. The other thing to be aware of is that we know time in the ER is really is something that you can't afford to waste. So a lot of the systems are also built around timely interventions, timely testing, timely recognition. And so, those alerts and those prompts, if you're not really using the device the way it needs to be used, because it's kind of like, I don't really like that. Unfortunately, it's a necessary thing, and it really needs to be something you view as a helpful piece of equipment, not an annoyance or something that's going to cause you more frustration, because it's really meant to help the bedside nurse and the patient.
Okay, so your attitude is really important when you are encountering that challenge. And that can often be the biggest challenge for many international nurses. So Farhad has a question for the panel. In the case of a bed crisis in a general ward, are there admitted patients staying in the ER, and for how long? Ben, can you maybe take that question?
Can you repeat the last part of that question for me, please?
So Farhad is asking, in the case of a bed crisis in a general ward, are the admitted patients staying in the ED and for how long? I think maybe
So
Fahad is
yeah,
referring
good question.
to during the pandemic. I'm not sure.
yeah. So every now and then your hospital may run into a bed crisis, and we have typically what kind of in our verbiage we refer to as a border in the emergency department. Different hospitals handle this situation differently. Some hospitals have inpatient nurses who come down and care for those boarded patients in the emergency department. Some hospitals rely on us as the emergency department nurses to take care of those patients in the emergency department. It just kind of depends on what the policy and procedure for your hospital is, as well as the availability of resources.
Okay, thank you.
But it does happen. We're seeing that it's happening a little bit less than it did happen several years ago, but it is something that comes around every few years.
So it can come up, and different hospitals, might handle that differently, Fahad. One thing that is not that different, and that everybody would encounter in any hospital, is that the work culture in the United States might be different. So our last segment that we're going to be talking about is the work culture in the ED. Sarah, was the work culture in the ED in the UK different to the US? And if so, how? Or if not, how?
Yeah, it was. That's one of the things that I found the hardest, actually. The work culture that the hospital that I trained in was it was a team nursing, because they didn't have ratios. So nurses would stick together and they would tackle patients in a team. And funnily, I hear this a lot on night shift. They do more of a team nursing approach on night shift, as opposed to day shift. In the US, you have your 4 patients, and those are your 4 patients. So that's one of the things that I struggled with rather than it's the ER, everybody takes care of that patient. It wasn't a pleasant experience in the beginning, but once you get to know the workflow, you get to know the staff, and when you are in a situation that your patients are kind of taken care of and you offer your help to another nurse, that was definitely, that helped me when it was the other way around and I was struggling and they were taken care of. They would offer their help. So just communication really helped.
So that was a big adjustment. So that's where, it's not sometimes just the clinical piece, it's also the work culture and dealing with a different model of nursing that can be so different and can take a bit of time to adapt to. Ivan, for many nurses coming from the Philippines, one of the biggest cultural differences is the relationship between the nurses and the physicians. Can you speak a little bit about that and how it's different and how you had to adapt when you came to the United States? What advice would you give international ED nurses coming from the Philippines?
Yeah, I mean, definitely they would be surprised, but yeah, in the United States, you're open for any suggestions. You can talk to the physician, and actually they consider like physicians and nurses like as equals. If you have like a suggestion, they will listen to your suggestions, and they would usually like order it as according to your what you think. So in the Philippines, actually, when the physicians might get mad, but some of them they think that they're godlike over there, so they think that the nurses are inferior, so they think that nurses should follow everything that they say, and the nurses should follow all the orders that they have ordered. And so yeah, I think this would entice the Filipino nurses to come here. Like that's what's beautiful here in the United States. Like all members of the healthcare are equal. So I mean, all of your opinions or suggestions are taken accordingly.
Okay, so a very big difference in the dynamic between physicians and nurses, not just in the Philippines, in many countries all over the world, and that it can also be a big area of adjustment. Yeah, go ahead, Sarah.
Yeah, can I just touch on that? Because that's one of the positive things that I found, in that actually for nurses in the US, that is expected. When you work with doctors, they expect your clinical decision making to come into play. So because they're very busy seeing multiple patients, so if something's wrong with your patient, they they expect you and they trust you as a nurse to come to them and say, look, I think we need to order this lactate, or I think we should do a repeat EKG. So that's one of the things that I really enjoyed about transitioning to the US.
So nurses have a lot more autonomy and independence in the care model. And for many international nurses, that can be a challenge because, as we said, nurses are sometimes taught in different cultures to be shy, to be timid, not assertive. Holly, what can a nurse do if you come from a culture where you are not assertive and taught not to be assertive?
I think the first thing is to acknowledge the difference, yes, it exists, and also to practice in less high pressure settings. So for instance, if you go to a store and you can't find something, it can be really hard to ask for help if you're in a place you've never been before, in a culture you're just learning. But speaking up, even in something basic, can be a way to kind of free yourself from that norm. Practice it even before you get here, when you're, if you're able to, in the country that you're currently practicing in. Sometimes it's a mannerism that's learned over the course of your entire life. It's not just in healthcare, it's your culture. And so you can find ways to say politely, this is really concerning for me. Do you mind if I share my concerns? The other thing is that assertiveness is not aggressiveness. So assertiveness is bringing something to the forefront and having a conversation about it versus really being pushy. And those are two very different behaviors. So practice is really what it's all about. But I'd say if it's totally foreign to you, start in your community, start in the new community, reach out, make friends. That's actually something you want to do to prevent burnout, is to start to build connections. And the way you do that is actually to be more assertive.
Okay, so lots of great tips and pointers there. And it's really just the mindset that I think is so important. I'm just looking at the time. We are almost at the hour. I cannot believe that the hour has flown by. This has been such a fun and interesting discussion. I think final words, let's maybe start with Ben. What would you say is your one biggest piece of advice? You worked in many EDs, you're very experienced in the US system, and you've seen as part of AMN many international nurses come through. What is your best advice to international nurses coming to work in the ED?
I think definitely research. The Emergency Nurses Association has a website out there that has a plethora of knowledge and educational resources that are available to you. Doing that research and kind of plugging out and kind of figuring out what is what, and knowing where to be able to turn to find those answers, as well as communicating with other ER nurses from across the nation and across the world. I think that's an invaluable resource to any emergency department nurse.
Yeah, absolutely. Agree 100%. And we'll post into the chat the website that Ben just mentioned for anybody who's interested in the resources that can be provided. And as Ben said, research is key, and reaching out to the community, which is what the LaFora Forum is all about. It's about community. Holly, what would you say is the biggest mistake that you see nurses make, and where you would like to maybe give your advice?
The biggest mistake would probably be making assumptions. So assuming one way or the other that you're not doing well, or it's not good enough, or that you are doing well. Assuming without clarifying and without communicating is probably the worst thing you can do. So it does go back, as we said earlier, to communication, asking for things, asking for feedback, being upfront about the things that you see yourself doing well in, as well as the things where you want to do better, and reaching out. Remember that there are resources. If you're connected with an agency like Kinetics, you have resources there. You also have resources in the hospitals, and you want to make use of those. If you don't, you'll find yourself drowning very quickly.
Yeah, I think that's great advice. Kinetics have many resources. AMN have many resources. O'Grady, that are part of our AMN family, have many resources, as well as many other reputable companies that do international staffing have many resources. So do your research and your homework in that regard. Sarah, in your experience of coming to the United States, what is something that you wish you'd known before you left the UK about working in the ED? You're on mute.
That's it. Something I wish I'd known.
Yeah.
Probably just to trust my own instincts a little bit more. At the end of the day, it's a patient that's in front of you. So no matter where you are in the world, you still have those clinical pointers that you know haven't gone through nursing school, haven't gone through your training. So just to trust yourself a little bit more.
Yeah, I love that, because I think for many international nurses, you're just thinking all the time, what don't I know? How difficult is it going to be? What a struggle it's going to be. But you're a nurse, you're a qualified nurse with experience. So you also have to be able to trust yourself. And Ivan, final words of advice for any ED nurse that is thinking of coming to the United States, is on route in the immigration process to come to the United States, has just arrived in the United States. What are your final words of advice?
Well, I think as what we mentioned earlier is what we need to learn in ED is learn how to talk and ask questions. So definitely we don't know all of the procedures, so we're not knowledgeable of all the cases that we're going to handle. If we don't know, then make sure to ask questions that we'll be able to avoid mistakes, because definitely, as we know, there's like lots of lawsuits here then, so that would protect our license. And I guess read more, as what Ben said. So open the ENA website, read more to be more familiar with what emergency nursing is about here in the United States.
Thank you, Ivan. So, and that's what the Lafora Talk Show is: researching, learning more, and really preparing yourself for the transition, which is going to be one of the most difficult, stressful, but also the most exciting and one of the best experience that you can do. As an immigrant myself, I came here 22 years ago. I speak from experience as well. So I wanted to thank Ivan, Sarah, Holly, and Ben for joining us. This has been a fun discussion. Thank you to everybody who's been watching from all over the world. The Lafora Talk Show will be back next month with a new topic. If you have a topic that you want us to cover, please make sure to put that in the chat. And we are one team. We want to make this as fun and interesting and informative as possible for you. And before you leave us, just don't forget the upcoming shows. So we have some upcoming shows on the Onwards and Upwards, the Kinetics channel. On the 23rd of September, we have the topic of how to rent an apartment in the United States. On the 7th of October, Next Generation NCLEX exam. On the 14th, we have our regular immigration Q&A. On the 18th, Lafora Talk Show, we are talking with the Philippine Nurse Association in the United States and what they can offer international Filipino nurses coming to the US. On the 21st in stateside, we'll be highlighting North Carolina. So what it's like to live and work in North Carolina. And on the 28th, we'll be speaking about your spouse. And last but not least, the Kinetics College. Every Monday, please check the time in your location. We have classes on Niners are talking about IELTS versus OET versus Pearson PTE on the 26th. PTE class by Swoosh on the 10th of October. Aspire class on the NCLEX on the 3rd of October. On the 24th of October, we have Niners again. And, oh, sorry, I missed it. On the 17th, first NCLEX from IPASS. And Niners on the 24th. So thank you everybody for joining us for the Lafora Talk Show, and we will see you next month. Thank you. Bye-bye.